So with that, I'd like to turn it over to Nancy Rios. Our first panel discussion is on the tribal leadership perspective on tribal community health needs. Our moderator for the panel will be Nancy Rios. Nancy Rios is the Regional Administrator for the Health Resources and Services Administration, HRSA Office of Intergovernmental and External Affairs, IEA Region 7. HRSA IEA serves as the principal agency lead on intergovernmental and external affairs, regional operations, and tribal partnerships. Nancy's office conducts outreach and provides technical assistance to stakeholders in Iowa, Kansas, Missouri, and Nebraska to increase the awareness, reach, and impact of HRSA programs and ultimately improve access to care in underserved communities within her region. So with that, please give her a big round of applause, Nancy Rios.
Good morning. Good morning. Oh, come on now. You all have breakfast this morning and coffee and caffeine in other forms. So good morning, everyone. Good morning. All right. It is an honor and a pleasure to be here today, and it was an honor to be asked to facilitate this panel discussion. I've been with the Department of Health and Human Services for 24 years, and out of those 24 years, I've been working with Tribe for 22. So I see a lot of familiar faces within this crowd, people that I can for surely call friends because we've been working on tribal issues for so many years. Again, I am really honored to just lead this conversation that's going to be about community health needs, tribal community health needs. And we have some changes in the panel. So what I'm going to do is I'm going to have each one of the panelists introduce themselves and tell you a little bit about them, what they do, and then we'll get the questions going. So Jay, how about we start with you?
Okay, is this on?
Yes.
Okay, I saw the little button here. I wonder if it's like a game show. If I know the answer, do I smack it before I
That would have been great, yeah, just to make it kind of interactive, right? Just have people just buzz for the answer. Yeah. Elizabeth, right. Why you didn't think about that?
Yeah.
Next time. All right, Jay, go
ahead.
So
I'm Jay Mooney. I'm the Health Center Director for the Prairie Band Potawatomi Health Center. I joined the tribe in 2017, was there for a number of years, and then the VA recruited me away, so I went to the VA. I was the COO here at VA Eastern Kansas in Topeka for about a year, and I decided to come back to the tribe, and I came back in March of 2022, and I'm happy to be back, and been back since then. So.
All right. Bridget.
I'm Brigette Robidoux. I am the treasurer for Sac and Fox Nation of Missouri. I've been on council for 13 plus years, and I'm also on the health board for the Iowa's Health Clinic.
Thank you for being here.
Thank you.
Misty.
Hi.
She's batting in for Chairman.
Yes. Hi, I'm Missty Slater. I am Chief of Staff for the Iowa Tribe of Kansas and Nebraska, and also a tribal member. Apologies, Chairman Rod wanted to be here, but there was COVID exposure. So he will be staying home to prevent spreading the virus to all of you. And so in addition to being Chief of Staff, I am also actually on the board for the White Cloud Health Clinic, which is the health clinic that serves the Iowa Tribe and the Sac and Fox Nation.
And Paul.
I'm Paul Austin. I am the clinic director and pharmacist at the Kickapoo Nation Health Center. I've been pharmacist for 11 years now and clinic director for 6 years coming up this October. So.
All right. So as we all know, American Indian and Alaska Native face massive disparities in health. We all know that. Native people suffer from higher rates of diabetes and related illness, heart disease, substance abuse, and mental health conditions than any other group. And as a result, the life expectancy of American Indian Alaska Native people is nearly 6 years less than any other race or ethnic group, and that is alarming. 72.4 versus 77.8, but I think those data points are a little bit old, so the difference might be a little bit higher. So I want to start by talking about the tribal needs, the tribal health needs and priorities. So I want you to talk to me about the current health status of your people, and then let's talk about those health needs that you have identified and those health priorities. So let's start with Jay. How about for Prairie and Potawatomi?
Okay. Yeah, so, historically, I think we've looked at diabetes has been an issue historically. I think in the last probably 5 to 7 years, we've made some really good inroads there with the special diabetes program in Indian Country, which many of you know is our DPP program, along with the efforts in the clinic itself. I think we've really done well. So historically, we talk about diabetes a lot, but I think over the last couple of years, I mean, obviously COVID, where you hear we have an absence today from COVID, so it's still out there. We're still vigilant and monitoring that. But I think that for us, our needs, the things we've talked about the last couple of years, we've really talked about youth, mental health, transportation issues, and long-term care for our elders. Those are 3 areas that I think we are looking to focus on, that we are focusing on, we're looking to focus on more in the next few years.
Thank you. How about Bridget?
A lot of our issues are the same as what Jay just spoke of. Mental health is a key issue, especially in our youth. Diabetes is big in our tribe. We have a lot of diabetes issues. We have a lot of diabetes programs going on. Currently, our issues have been COVID long-term effects. We have quite a few members that contacted COVID, and they have long-term disability issues. We lost quite a few tribal members from COVID, but the debilitating side effects of having COVID for some of our members is very traumatizing for them because they can't do basic things. So COVID issues and diabetes are our main issues right now because they're our #1 killers.
Misty.
Yeah, I would say chronic disease, diabetes, cancer, of course, are big major issues. Of course, the infectious diseases like COVID, another major issue, and mental and behavioral health issues is another focus of ours. But in addition to that, the tribe is really trying to take a really holistic approach to how we address health. So that will include looking at the entire lifespan and making sure there is access to the kind of care that people need based upon where they are in their lifespan as well. So whether that is, prenatal appointments, even, before birth, all the way to long-term care and nursing home access for our elders. So we are really looking across the lifespan and also exploring some of the root causes for those conditions as well. So I think most of the folks in the sort of health arena think of those as the social determinants of health. So we are exploring things like access to the most appropriate housing, access to really fulfilling career paths, access to early childhood education. Those are some of the things that we're also looking at to prevent issues later in life.
I think Jay pretty much, just copied all of my points. But to drill down a little bit deeper in a couple of them, mental health services is definitely a huge thing. But to go a step deeper, when we had some feedback from our youth through the Circles of Care grant, the most common feedback I got was they didn't only want mental health services in the clinic, but they also wanted mental health services provided by Native Americans. And so that adds an extra layer of trying to meet that need of getting more specific kinds of providers than just whoever will come to our rural clinic to serve our people. Transportation continues to be an issue for us, even though, we provide transportation, we provide gas cards. Currently working with some of the federal level folks on the MCOs fulfilling their requirements to providing transports for the people with Medicaid. Some of the feedback that we have gotten from some of our patients are, being told that we're too rural for them to come and do the transportations, down to Topeka. So we're currently working that problem. Recently we've had a few patients, be diagnosed with cancer, and so we have to transport. With us being up near Horton, it's quite a drive down to come to Topeka or to Kansas City for their infusions and for their treatments, and it's usually an all-day thing. So right now we have 2 patients that kind of alternate on the days, but if they end up on the same day, it's kind of hard for us to transport anybody else to any other visits on those days. And then probably the one area that's kind of specific to us, because I think we're probably in the smallest clinic out of the three of us, is definitely space. Of all the problems that we're probably going to talk about here today, the things that I want to do to meet those problems and fix them is kind of limited by the space that we have. And we really need a larger clinic and more space to add positions to do those things. And so that's kind of probably our biggest thing.
Thank you. And I'm so glad to hear you all talking a little bit about the social determinants of health, because I was reading an article that said 50% of the impact or the positive results of any clinical care, it's tied to social determinants of health. So it's just addressing transportation, addressing housing, addressing access to clean waters, to food. And so I know all the tribes are working on some of those things, and it's great that it's forefront in terms of your planning and developing strategies to address those, so then the clinical outcomes can be positive and you have better results in getting people compliant and get people healthy. So kudos to you. We're going to continue to talk about social determinants of health as we talk. I think in terms of the federal sector, I think you will see a lot more funding opportunities that come from federal agencies adding that component to it. It's not only about focusing about increasing access to care, but in order to increase access to care, have positive health outcomes, we need to then be thinking about the social determinants of health, partnering with those organizations that can then help provide those kind of services, so then the approach can be more comprehensive and holistic based on the needs of those individuals. And I know you all doing that. And I always tell folks when I'm talking to non-tribal people that if you look at best practices, you need to look at tribes, because you have been doing this for a long time. I'm talking about doing patient-centered type of care, doing holistic approaches to care. So with that, I do have a question about long-term COVID. So what is that you're seeing, Brigette, and where are you sending people to get care? Because I know with long-term COVID, there are not a lot of places that you can send someone to get care because it's just kind of unknown. So how are you all addressing that?
There was muscle deterioration, permanent damage. So a lot of them are having problems walking. Mm-hmm. Lung damage. So not only can they not walk, they can't breathe very well. Brain damage, permanent brain damage was also affected. We're mostly sending them to specialty clinics here in Topeka. They come to the clinic for their normal checkups and evaluations, and then we outsource them to specialty clinics.
Wonderful. In terms of mental health and issues, behavioral health issues, we hear time and time again, not only in Indian country, but also in the rest of the nation, that with COVID, you have lots of people seeking mental health, behavioral health services. And so in thinking about the priorities pre-COVID and now post-COVID, have those priorities change or shift for you all, Jay?
I don't think they changed. I think what COVID did was really exacerbate the current issues. We know diabetes is more prevalent in Indian country. We know mental health issues, and I think what COVID did was just make those worse. And obviously people that had comorbidities fared worse during COVID. And then one of the long-term, the long haulers, as they say, mental health is a big piece of that. Mm-hmm. And I think what it did was really exacerbate the need, more so than really change it.
How about for you, Misty?
Yeah, I would say the priorities haven't necessarily shifted so much as the way we're addressing the priorities has shifted. Society as a whole saw a change in the way that we've approached public health during COVID, and tribe, at least the Iowa tribe and the public health services we provide the Sac and Fox Nation has shifted too. So the ability to tap into technology and the funding that allowed us to expand our infrastructure to allow for more people to access broadband, to access internet, has been helpful. So the ability to communicate more effectively through technology about some of our health issues has changed, and it has changed for the better. Now, I think some of the issues have been exacerbated, some of the disease issues, some of the life expectancy issues. And then the, I guess, more polarized environment as a result of COVID, and the more polarized environment, particularly for public health. That is the same on the reservation as it is off the reservation. In fact, sometimes it feels like a microcosm of the larger society, and that the folks on the reservation might have one way of thinking, where the folks immediately outside of the reservation and the small town surrounding it have very different ideas. So I would say those approaches haven't changed, but our need to rely more on a community support system has probably been uncovered and revealed in ways that we didn't see these facets prior to COVID.
Thank you. How about for Kickapoo, Paul?
Well, I think it definitely sheds some light on things that need to be done better, weaknesses in our clinic, I guess infrastructure-wise, things like coming from a retail pharmacy. You may think a drive-through pharmacy is just a convenience so people don't need to come inside, but during the pandemic, that definitely would have been something that would have kept people safer by allowing them to stay in their cars to pick up their medications and not have to come into the clinic where there potentially are people that are, sitting there that could be infected with COVID. So, something like that. How we would handle mass vaccination events with our small site. We really didn't do that. We handled it with more doing just all-day vaccination appointments and scheduling them and doing it that way. What do you do, when you've got 2 people that are COVID positive and you've only got 2 exam rooms, and how do we treat other disease states in that kind of a world? And so it definitely made us look at infrastructure changes, or scheduling changes, or how workflow changes, and how we were going to address that.
Thank you. And I think now that we've been listening to the news and Chairman Rod going to the exposure, I think we're going to have to become more alert in terms of protecting ourselves, but also for clinics just kind of getting ready once again to a potential outbreak. So it's good that you have the time to just reflect on what worked for the clinic and what you need to do in terms of moving forward to prepare yourself if something like that happens again. God willing, it will not, right? Because I think we already, and actually, if you look at the statistics in terms of effectiveness, in terms of getting people vaccinated, tribes, we're stellar. We actually look at those models and encourage other providers to follow some of your models in some cities and counties as well. So kudos to you, but there's always room for improvement in everything that we do in terms of health. So I know some tribes conduct community health needs assessment, and those assessments help the tribes identify those health priorities, those needs, and with that also develop a strategy to address those. And those assessments can be formal and informal. Can you talk a little bit about how do you went about identifying the needs within the tribe? Was there a formal process? Was there any community involvement? And if you get any kind of feedback from the community. So let's start with Jay. How about Prairie and Potawatomi?
Yeah, so our last formal community health needs assessment was way back in 2016 or 2017. A result that came directly from that was our building of our new behavioral health center that we opened up in 2018. That was using that feedback that we got. That prior to that, our behavioral health program had been, I think, 3 providers in a hallway, tucked away in social services, and so it became a priority for the tribe, and that directed us towards our building. And so we're due for another formal community health needs assessment because it's been a number of years. But in the meantime, we try to be data-driven. We strive for that. And we're constantly looking at all of our clinic numbers, our health data that we have for the tribe. And that's really driven us to a number of things we've done over the last few years. Right before COVID hit, we had started our dental expansion. So we've doubled the size of our dental clinic. And if you don't need dentists, send them my way, because we're still trying to recruit our second dentist. Recruitment's been, we're going to talk about challenges, I think, here later. Recruitment, I think, is a challenge we're all going to talk about. But we've expanded dental, reviewing our data. We are adding a mobile MRI. We looked at our numbers of patients who need MRIs and the challenge it was to get them somewhere to get an MRI. So we're going to have a mobile MRI come on site once a week, and we're going to start that in the next month or so. And so a lot of little initiatives like that that just come from a constant. You have to, I mean, the community health needs assessments are important. You need to do those every few years. But you've got to constantly be able to look at your data and be data-driven in all your decisions. And so, another big need we've talked about since before COVID, and it was exacerbated during COVID, was long-term care for our elders. The tribe's been looking at how can we meet that need, and something we've been able to do with some grant money is to create a home health group. We've got a couple new home health aides. We've got vehicles for them. We started that program this summer. It's been well received, and we know that's just going to grow over the next few years. And that's, maybe we can't build a long-term care center, but if we can keep elders in their homes through those, in-home health aides, that's huge for our tribe. And so that's been another thing. Again, it's the data. It's collecting the data to see what the needs are and then addressing the needs, being data-driven.
And when we were talking about the questions for the panel, Misty was part of the call, and actually she brought a great point about, like, there are many ways on how tribes are collecting that data and how they are strategic about pushing forward, developing those strategies to address those needs. So, Misty, talk a little bit about the Iowa.
Sure. So we did do a community health needs assessment a number of years ago, the same time I think most of the tribes did as a result of the Healthy Kansas Tribes 2020 or something along those lines that the Kansas Department of Health and Environment helped support. But since then, rather than doing follow-up community health needs assessments, we've been able to use other sources of data. So we did do a larger overarching community needs assessment that included some health needs. So we were able to do that about 1.5 years ago. And in addition, I know Brigette knows this as well, we definitely look at different clinic spend line items. Particularly in our purchase referred care department, we will look at what are we spending the most money on? What services are we referring out as the most popular services? And then we're able to kind of help back that up and say, okay, so if we are sending all of these patients and they're having to drive to Kansas City or to Topeka or whatever the case might be, what can we do to help reduce those barriers for our patients, meet their needs, but also a lovely byproduct of that is helping save the clinic money.
Yes.
If we're able to provide those services in-house, it saves us money while also meeting the needs of patients. So it's totally a win-win. Our community members get the services they need while we get to use those funds that we would otherwise be spending to send those patients to other providers on other things that the clinic really needs, on other services that we simply could not provide in-house. So I'd say that has been where we've been and kind of where we want to go moving forward. We want to look at truly, as we look at our health needs, we really do look at our social determinants of health. So doing just a community health needs assessment might actually be putting blinders on some of the issues. So we're actually looking at embedding some of these needs into a larger master planning project. So including health in reservation master planning. So again, another challenge would be, how do we find funds for master planning that also includes health? That's a big need. That's a big lift. That's a big ask. And so that's going to be something that we need moving forward because it doesn't fit neatly into a box of health. It doesn't fit neatly into a box of infrastructure. It's truly a holistic community approach to how we improve health, the economy, and the overall quality of life of our members.
Communication is also key. Our clinic, I am very proud of our clinic. Most of our tribal members are proud to go there. We have a great communication with our patients. The councils, both councils have great communications with our tribal members. We try to get involved. We just don't stay in our offices and do our business. We get involved with their personal lives. On a health level, we try to communicate, keep communications open. What is our elders needing? What's helping them to survive better? What do they need to function better in their daily lives? And get involved with our youth. What's anxiety levels in our youth is so high right now. And to talk to them, all they need is someone to talk to. And our clinic and our providers at the clinic are very they're like family to everyone. So that's a key issue is communication.
Involving the full community.
Yes, the full community. It does truly take a tribe.
How about Kickapoo, Paul?
It's been a few years since a full community-wide health needs assessment was done. The latest information we've gotten has been kind of tied specifically to the various grants that the tribe has gotten. Like I said, the surveys that were done during the Circles of Care grant definitely illuminated some views from our youth of what they needed for, or what they wanted for mental health services. I went and met with the leaders of that group because, you know, some of them were misconceptions. They didn't understand. One of the first things they said to me that they didn't feel if they came to the clinic, you know, their information was going to be, you know, held confidential. And so, you know, I just had to, they didn't understand HIPAA law. They didn't understand that, you know, we can't share that information. And, you know, and so I talked to them about that and assured them that, you know, we have strict HIPAA guidelines to protect their confidentiality. And so they seem to, you know, like to hear that. The other thing next up is our behavioral health integration grant that I oversee. One of the aspects of that is to have a mental health committee or board that's made up of community members, and I think part of that will be a mental health needs assessment for the community as a whole. So that will definitely, as we go to year, by the time it gets set up and going, as we go into year 3 of that grant, that will definitely drive the last 3 years of that grant as we get all the pieces in place to administer the end of that grant. So.
One thing that resonated with me, or that just kind of stay there, that I want to just address, it's what Misty say about bringing more services to the clinic to save money, but then also make sure that your tribal members have access to quality care and to providers that know them and that can provide culturally sensitive care. I remember when I started working with tribes, there was one line that was one of the first lines that I learned. Whenever you're talking about contract dollars, do not get sick after summer. Because usually if you try to get specialty care after summer, there will be no money and you have to wait, or you have to beg the tribe, see if the tribe has money to then out of their tribal funds be able to provide for that care. We know that the federal government is supposed to fulfill its responsibility to provide health care to American Indian, Alaska Native through Indian Health Services, and that's just not a lot of money, right? It's not enough money. So I know you all struggle in terms of getting the funds needed by having to apply for so many grants, and I know that can be a challenge. I also have to say that when I started, working again with Tribe 22 years ago, I remember the first time I went to Prairie and Potawatomi. I remember the first time that I went to the Kickapoo Clinic. And I remember the White Cloud Station that was run by IHS. And now you go through all your facilities, and it's just amazing the work that has been done and how much you all have grown in terms of the services that you're provided, the amount of patients you're taking care of, and then how you were open to engage beyond other tribes, other key partners for the benefit of your tribal members. So I had to make that statement that you're all doing a wonderful job in terms of ensuring that you are paying attention to the needs of your tribal members, but also having that open mind of like where we can go to get the funds, because we know that federal trust responsibility is not totally being met. So with that, I want to talk about the challenges that you're facing in addressing those health needs in tribal communities. And I just gave you one, right? How much? 30. Okay, we're good. 30 minutes. We talked about having to then tap into so many different agencies to apply for grants to be able to bring services. So that would be one of them. But I want you to talk about, beyond that, what other challenges are you facing and how are you addressing those? So let's start with Paul, Kickapoo.
Number one would be finding candidates to fulfill the roles that we need. To hire psychiatrists, psychologists, counselors. Our grants, some of our grants have had positions that have been open for over a year because we can't find people to fill them. I know when, I guess it was 4 years ago now, when our provider left us, trying to find a appropriate replacement provider was hard. We had we went with a company recruiter to find us one, and we got 3 applicants. One was a 86-year-old person from California that wanted to come here, somebody that wanted an exorbitant amount of a sign-on bonus, and another not so great candidate. So finding somebody to fill that role was definitely difficult. And so that's probably the biggest thing whenever something pops up, to find somebody qualified, especially for the degreed professional roles that we have in the clinic. Something else too that does kind of raise its head for us is the IHS defined service areas for us. We're required to treat certain tribes that live in certain counties. But the problem is when Kickapoo people don't live in those counties. Mm-hmm. Through IHS's service areas and purchase referred care, we can't utilize those federal funds to treat a Kickapoo person that, say, lives in Kansas City. And we have a few of those, or a Kickapoo person that lives in Lawrence. They're not within our service area. So the tribe has to find a way to, utilize the Kickapoo Tribal Health Fund to meet their needs. Just because they don't live in one of the 2 counties that we're responsible for doesn't mean that they don't have needs, to go to the emergency room or go to specialists. And IHS doesn't really allow us through the federal funds and the purchase of referred care to meet those needs for them. And so that's definitely a challenge for us.
Thank you. How about Missy?
I would say 3 of the biggest challenges, and Brigette, I'll also let you chime in too, would be staffing, space, and funding. I would say those are the 3 biggest challenges. Staffing, you said it, Paul, in rural areas, it can be really hard to recruit staff that want to come and want to stay.
Quality staff.
Quality staff too. Not the folks who have been fired everywhere else. So they're like, well, I guess I'll apply here. Yeah, quality staff, and then space. When we do have a tribal member or a community member who says, oh, I'll use an example of just my brother. Oh, I'm a physical therapist. He just graduated and he's a doctor of physical therapy, but there's no space in the clinic to actually start physical therapy services. So we'll need more funding to do more construction to create more space. And then the reservation is only so many acres. We only have so much land. So how much of that land can we actually expand? Because we have a limited number of space. So I would say those are probably the 3 biggest challenges. And Brigette, I'll let you expand on that.
A lot of grants don't cover brick and mortar, so you can't build a building with grant funding. You have to come up with funding yourself. And right now, construction is ridiculous. The cost of materials is ridiculous. The labor is ridiculous. And if you don't have the space to expand, your tribe is going to suffer for it. Your people are suffering for it. You can't get physical therapy. Currently we're doing an X-ray lab. We did dental. We have a dental lab. What else? Eyeglasses. Mm-hmm. But we only have so much room, and in order to provide for the X-ray lab and the eyeglasses lab, we had to move the gymnasium. And it's like in a modular unit right now. So, and physical health is just as important as preventative health. So you have to pick and choose what's important at the priorities for your people. So yeah, I agree with Misty. Those are our biggest challenges, and getting reliable, dependable staff that's qualified in rural areas is very difficult. Nobody wants to live in the middle of nowhere and not get paid the big bucks like they would in the city, and nobody wants to commute like that. So we have challenges. We have to think of different incentives because it's just really hard for us. We do get the rotten apples that fall out of the tree.
So Brigette, how are you doing recruitment right now?
We are interviewing almost everybody, and the ones that we do hire, we pray. We definitely pray and cross our fingers and watch them very closely and pray that they are are what we hope they are.
Well, you're going to
And
have
we
to
have
send
been
us all an
lucky.
email so we can pray with you.
We have been lucky. Our clinic has been lucky. We had one bad apple, and we had to find out the hard way. But
So how did you promote your openings? Do you just put it out there in the newspaper, or you utilize IHS to do that as well, to put the postings out there?
No,
do you get any support?
I would say what Bridget shared earlier about the council and the staff having incredible lines of communication with our members. I think that's probably the main way. We put a lot of postings on social media. We talk to our members, and we just have social media and word of mouth help spread the word as much as we can. We don't necessarily go on LinkedIn and put a bunch of posts on LinkedIn or boost it that way or anything like that. It's pretty much social media, word of mouth, and hoping our message hits the right ears at the right time.
we like to hire within our tribes.
That's great.
And we kind of just know, like, we keep track of who's going to school for what, and then we reach out appropriately when we're like, oh, it's May, that means they might be graduating. We know which of our community members are going to school for what, or which community members have different types of expertise. And so, yeah, sometimes we just call them up to gauge their interest in changing positions and try and poach people that way too.
Yeah, I think more than ever, it's important for us to educate the youth about healthcare careers, to just incite them to just get into those fields, provide them the support they need so they can be successful, and then bring them back to the reservation so they can provide care within your.
It's very important to inspire your people to give back, because they're not realizing that our youth is really needed as they get older. Their education that they receive, that we're funding for them to get educated, bring it back home. It really helps us, and you're helping your own people. So we really kind of mentor that into our people.
Well, and we hope also that a lot of tribes start thinking about creating pipeline programs, so you have someone that's working at the clinic that might be front desk, and then maybe you can get them to say, hey, how about if you just at least get your CNA, or just move on to, or you have a CNA, let's kind of get you there to be a registered nurse, and then keep them there within the clinic. So yeah, I'd love to hear those kind of strategies to get people in, and would love to continue to partner with you to see we can help you with the recruitment piece. Jay, can you talk about the Prairie and Potawatomi challenges and how?
Yeah, so I'll echo the recruitment. Recruitment's has been a challenge for us, especially right now. Where, again, I mentioned the dentist earlier. If you look at USA Jobs right now across Indian country, there are 20 dentist vacancies, and there's a list of 5 guys coming out of school for the commission corps. So it's challenging. It's competitive, and so with that in mind, and across the medical field, it's competitive. We saw a large exodus of healthcare folks during COVID. A lot of burnout. A lot of people quit. And so those that remain, it really is a employees market right now, and so you've got to be able to do some things that are competitive. One thing we did that has helped with our physician recruitment is we've offered a 4-day work week. So we'll do 4 days, and of course, if you've got a bunch of physicians, you want to make sure they're staggered so you don't have a day with no physicians. But doing little perks like that, if that can help with recruitment, that's definitely a boon to us. You have to tell your story. You have to be able. You have to get it out in every venue you can, everywhere from LinkedIn to social media. You have to advertise in all the journals for all the different schools. But really, you have to tell your story. You have to show why you're the best place to work. And I say this all the time, that Prairie Band, we are the best kept secret in healthcare in Kansas. It's a great family atmosphere. Our patients are fantastic. Our tribal council's supportive. It's a wonderful place to work, but you've got to be able, no one knows about that. I mean, I admit when I was recruited, they called and said, hey, would you like to come up here to Mayetta? And I said, what's a Mayetta? So, it's, but you have to be able to tell your story and get it out there of the great things you're doing and how care is different here than it is, with the machines of the larger hospitals of the world, how we do things different. And we really care about that individual patient appointment and taking care of the one patient that's in front of you. We're not such a big churning machine of how many patients can you see in a day. We do things different. You've got to be able to get that message to your recruits, because it is competitive out there for sure.
Well, what is also great is that if our clinic doesn't provide something, we contact the Potawatomis, and we all help each other out.
Absolutely.
We work together, and that's very important.
How about the other priorities that you talked about, Jay? You were talking about elder care. You were talking about mental health. What are some of the challenges that you're facing right now?
So I think in mental health all the time, I think our challenge is always our transportation. We have a need to get patients in residential treatment facilities, and there's not a lot of residential treatment facilities in Indian country. They're long distances away. To get a patient to a residential treatment facility outside of Indian country can be cost prohibitive, especially if we've got uninsured patients and that sort of thing. So transportation to that and identifying those, that is a big need. Youth mental health. I mean, we know we don't do it. We have, it's not our core service. We have this great behavioral health building, and we take care of adults, but we don't have a pediatric mental health. And there's some regulatory things about why, because you can't mix those milieus in the same building and things like that. But we know that that's a gap for us, and we're exploring ways through grants that we can, what can we start doing to get the youth mental health. And it's again, COVID has exacerbated it, and we know it was a need before, and it's certainly a need now. So I think those are kind of our big ones that we're looking at.
And I know Misty also mentioned telehealth. Have you been able to tap into telehealth to just address, for example, the pediatric mental care?
We have, yeah. In fact, one of our grants we're looking at with our behavioral health manager, Tony Siebert, I don't know that he's here today, but one of the grants we're looking at is we're hoping to set up telehealth where if we can set that up in the Boys and Girls Club or somewhere where we can have a technician running the clinic, and then the patient can come in, sit down, and then be able to telehealth with a psychiatrist somewhere, wherever that psychiatrist may be. That may be one way of filling that need.
Do you feel that tribal members were embraced telehealth? Was that a challenge to get them to actually
I think that's mixed.
Utilize it?
I think it's mixed. I think it's a little generational. I think certainly the younger patients really have embraced it. In fact, they want it. They want to just look at their phones all day, and get everything through their phones for sure. But I think it's for the most part it's been embraced, and we really ramped it up during COVID. And then as the COVID numbers went down and we opened up the clinic, I think that we saw that sort of drop off. I think people at the end of the day, they want to be in the room with their provider.
Absolutely.
Yeah, for sure.
How about Brigette? Do you have anything in terms of telehealth or Misty or Paul?
I think there's a lot of people are very discreet on the reservation. So telehealth has helped them a lot. A lot have anxiety about leaving their homes now that COVID has had us stationed for so long. So telehealth has helped there. But there's a lot of elders that have difficulty getting on.
Misty or Paul?
Misty.
Oh, Misty.
Thank you, Brigette. I would say that we are currently looking at trying to expand the ability that we have to support our patients to access telehealth services. We've sort of dipped our toe in it a little bit, but we haven't really fully explored all of the avenues to expand to telehealth. But with the increased electronic communication that we've been using over COVID, there is a growing interest, I think, and as Jay said, generationally, there's a growing interest to address telehealth. So I think that's a direction that we're moving in, but not just to supplement our in-person health, not to replace our in-person healthcare services.
Pre-COVID, we really didn't have a lot of telehealth visits. During COVID, we started utilizing it, and there has been some after use. We're seeing more of our patients that are going to see specialists using telehealth for those. A few then will come into the clinic to utilize tablets that we have there to help them do that. One of the problems, I think, on our reservation is that, not all the homes have broadband. I know the tribe got approved for one grant, and I don't know where it's at in the implementation of that. But what may be a little different from us, one of the things that did come out of that Circles of Care meeting that I had with the youth was they actually didn't I told them that, one of the things that we, how we can help them is, we can do referrals out and send them out for behavioral health or mental health meetings. And one of the things that I was working toward is to try to get some more settings for, telehealth visits for that. And their feedback they actually gave me was that they didn't really want telehealth visits. They wanted in-person visits. And so, that I was like, well, we may have to use this as a bridge till we get to the point where we have the staff on. And I reached out because I was like, well, surely there's got to be a tribe someplace in this country that is doing that and providing that service that maybe we could tap into, so that while they may not necessarily like the idea of being telehealth visits, if they're telehealth visits to a Native American provider, that might be the selling point for them. But I didn't really have any luck to find somebody, a tribe out there that was doing that. But it would be really nice if there was.
Thank you. So I always like to kind of go the direction of like success, right? We talked about the challenges. I want to just then have each one of you share successful interventions or strategies or programs that you're currently implementing to address your tribal health needs and priorities. Any kind of impactful interventions, and if you can share stories with us, that would be great. I love hearing personal stories of people that have been impacted by your program. So let's start with Bridget. So
I'm gonna throw it to Misty.
Come on, Bridget.
Okay, I'll start, Bridget, and then you can.
She didn't hit her buzzer.
Yeah.
Next year we'll have the buzzer for sure.
I will say, with the Iowa tribe, all of the decisions that we make very intentionally with life at the center of every decision. And when I say life, it is not just human life. It is the life of the plants, the animals, the earth, the water, all of our non-human relatives as well. So when we talk about life being at the center of our decisions, we truly think holistically in how we address that. So I would say some of the successes that we've seen has been really looking at, okay, if folks are having diabetes issues, that might mean that their diet has been westernized in a way that does not positively impact their blood sugars. So how do we address that? Well, we address that by changing the food system on our reservation. So we have switched over the last few years all of our agriculture to regeneratively grown agriculture. So that means that life is again at the center of agriculture. That's the microbiome of the soil. That is the water quality. That's the nutrient density in the plants that we're growing. That is rotational grazing as well. So then our animals are the healthiest animals that they can be. So then when we harvest those, we are again getting the healthiest and happiest ecosystem that we can, putting into the bodies of our members. We saw during COVID that those food system supply chains were massively disrupted. And we also saw, I don't know, is anyone here from Meskwaki Nation? Particularly, we think of some of the meat packing plants and how hard COVID hit our meat packing plants. And I know that there's a meat packing plant very near Meskwaki Nation. And I heard the dramatic impact that had on the Meskwaki Nation members that were working at those meat packing plants. So we don't want to contribute to that either. We don't want our health to come at the expense of someone else's health. Mm-hmm. So we have started to change our entire food system, change our water quality, change our air quality, mitigate the impacts of climate change through some of these more holistic interventions. And now we're going to, through a couple of grants that we've recently been awarded, make sure that those foods are in the refrigerators and on the tables of all of our tribal members. So we don't have the data to back up, oh, well, we were able to implement this, so our diabetes rates went down this much. But because it's such a slow process, we have just gotten the funds. So we now have well over $1 million that we are getting both in federal funds and from a partnership with the American Heart Association to implement food as medicine prescription program in our clinic. So anyone who is food insecure or has different diagnoses in which healthy food could positively impact that, they can get a prescription for those healthy tribally grown foods. And then there's also a federally funded local food promotion, I can't remember the LFPA, and it's a local food, I can't remember. Yeah, maybe that's an LFPP. I can't remember. Well, we are actually going to be able to take our tribally grown food and distribute that directly to our members at zero cost to them. So rather than having to hurt our tribal economy because we can't continue to afford to grow all of these foods and not make any money, we are actually able to supplement that, not lose any money, and still feed our tribal members. So we are also looking for some indigenous researchers to help us. We really want to make sure that this is an indigenous-led research to make sure we are positively tracking our outcomes and reporting those outcomes so we can sustain and expand on this program in the future.
You see why I threw it at her?
Yes. I would have done the same thing. You know what I mean? I would have been like, you take mine. You go, girl. Amazing, amazing work. Thinking about the link to diabetes, we need to talk because there's a Rural Health Network Development Planning grant that you might be able to tie what you're doing to diabetes treatment. So we'll talk about that.
I remember seeing that grant.
Yes.
And now I'm thinking, I hadn't actually thought through this through a food lens, but that could really.
Yeah. All right, Paul.
Probably our BH2I grant, Behavioral Health Integration Grant, that we've had now, we're going into our second year with, is going to allow us to meet the needs of the mental health. We have a PRN nurse practitioner that is, through that grant, being trained to specialize in mental health to handle the mental health prescribing for medications. So that's going to be kind of the cornerstone of that going into year 3. And so we're on target. We're actually a little bit ahead of target, but some problems have arisen us being able to bring in, getting an appropriate candidate to handle the counseling portion of what this grant is going to do. So we're potentially shifting some gears and going to use some paraprofessionals to do brief interventions to kind of bridge the gap until that happens. And so I think once that happens, we will have our fledgling mental health services there at the clinic.
Great, thank you. Jay.
Yeah, so I mentioned earlier our looking at grants for youth mental health. We're excited about that. But something else to go back to telehealth a little bit. It's not, during COVID, telehealth kind of took the place of patient visit, provider visit. And so, but we don't really want to look at it like that. We want to look at how do we use technology to leverage what we're doing? How do we use it in tandem with, not in place of? And so, we think of behavioral health. And so, you have a behavioral health patient, they attend group, they attend their session, and then they may have a week or they may have 2 weeks before their next group session. So we're going to be putting a press release out in the next couple of days of an app we've just contracted with that's 24/7 access to care right through their phone. They can get providers, they can get groups, they can do all kinds of things. So if they feel they need a touch point before their next appointment, they have that touch point. So to me, that's using telehealth, that's leveraging technology, using it in tandem with what you're doing in the clinic to supplement it rather than saying, oh, we're going to just sit down and do this, through the screen instead of a provider visit. So
the app is just specifically for the youth?
No, the app will be for any patient. Yeah, any behavioral.
And it's just mental health or all kind of services?
It's mental health.
Okay,
now, yeah.
Wonderful.
It's through a company called Chess, and so we're going to be putting a press release out this week on that. And so that's something we're excited about. I mentioned the mobile MRI. That helps our transportation challenges, getting folks that need to get an MRI somewhere is tough, and so to be able to do that right on site.
I heard about the mammography too.
We're going to look at that. We've got when we built the expansion, we've got the 2 pads out on the one's for the mobile MRI and another one's for to be determined. So we're looking at things like CT. We'd love to have our own CT capability at the clinic, and we're looking at mobile mammography. But the good thing about mobile mammography is you don't necessarily need the specialized pad for that. You can roll the bus in and kind of put it in any parking lot. So yeah, there's definitely stuff we're looking at that we get excited about. Our clinics our new expansion has space for PTOT. We're looking to do that in the next couple of years, and there's going to be a lot that goes into that. But if we can bring And again, it's all about, as mentioned earlier, saving those PRC, those purchase referred care dollars. And the more we can do, we talk about sovereignty a lot, and true sovereignty is that we take care of our needs. And the more we can do right there in our clinic for the people, the better we all are for it. And we save our PRC dollars, and it becomes this cycle of revenue savings and care that we're giving. So
yes, absolutely. And bringing revenue to the clinic, it's so important. So that's why it's important to ensure that all your tribal members are enrolled in care, some kind of insurance, so then that way you can just have them come in, provide their services, bill those insurance companies, and then be able to use those dollars to increase access to care within your clinic. So it's, again, you guys are doing wonderful.
And Nancy, I'll say, when you say enrolling in health insurance and getting access to care, I want to point out another really great program. When we talk about saving purchase referred care dollars, it's not about not spending those. Right. It's about being able to spend those on other things. Mm-hmm. So it's not a corporate model where the money you save goes back to the shareholders. Mm-hmm. The money you save goes back into other services. But one of the services that we use some of our clinic dollars to actually cover is Medicare Part D premiums for our elders. Mm-hmm. What we found is many could not afford even the small amount of premiums. So it was, maybe a year ago or so, we started looking into what we could do, and we started covering the Medicare Part D premiums for our elders. And I don't have the numbers as of today, but within the first 4 months of that program, we had a 4-to-1 return on investment. So in the first 4 months, for every dollar we spent on premiums, we had $4 extra in revenue being brought in. So I say this because if we're seeing that at just our clinic, imagine if we removed or reduced those barriers for everyone across the country. We saw a 4-to-1 ROI in just 4 months. Imagine the possibilities if it was expanded.
Yep. And I know there was a conversation about figuring out how to do Part B, but Part B, it's a lot more complicated because the premiums have to be deducted directly from Social Security. So I know that was going to be a challenge, but there were lots of conversations about also ensuring that that Part B piece that pays for some of those outpatient services and regular primary care services were something that the tribes could just pay on behalf of tribal members. So with that, we have 5 minutes. I wanted to open up for questions. I'm the next speaker, so I can just kind of yield my time to continue discussion. I find it so interesting. So I want to just put it out there, folks, just ask questions. And please introduce yourself. And
my name is Deborah Bolton. I'm a geographer and work at Kansas State University. And Okiawinge Nation is mine, what the Spanish settlers called San Juan Pueblo. So my question to you all, do you think that the conversation would change just a little bit if we quit using social determinants of health and called it political determinants of health? If you look back to the founding of this nation, so-called founding, right away there were laws and policies to exclude and minoritize our people. And with every treaty that was broken with us, we can even look at the treaty maps. Every time there was a treaty, the land shrunk and shrunk and shrunk. Ask the Osage and the Kaw, for example. They used to be in Kansas. They were pushed out to a little tiny place in Oklahoma. And we could trace so much of the problems back to that minoritization and those exclusions. We weren't allowed to have land. Nobody really understood why we moved, so we didn't overuse the land. And then we live in an extractive economy that doesn't care about the care of the land like you just spoke about. So I think maybe we need to change we need to say what it is. It's political determinants of health.
Thank you. There's one question back there.
There's been mention that one of the main barriers to the work you're doing, I mean, besides the issues related to space, but finding funds for capital improvements. I'm Christy Davis with USDA Rural Development, and we do a lot of capital improvement type projects in rural communities. I'm curious if you all have had experience with USDA Rural Development. If so, what works, what isn't working, how can we help?
we don't have any experience, but it's the cornerstone of my proposal to build a new clinic. So it's sitting there within the proposal that's ideally probably where we'll seek funding from. So.
Sac and Fox has had experience. It's the brick and mortar policies where you have to have pre-existing ground. Most of our pre-existing ground needs to be rehabbed anyways. So USDA says we have to have pre-existing electrical, plumbing, cement in order, like a foundation in order to build something. And we need new builds. We need fresh builds. And so we can't utilize those grants.
And I have heard about the grants versus the loan, and even though the loans are very low interest still for some tribes, that it's just kind of frightening to go on into a debt and not knowing where those funds are going to come and how you're going to pay it back. So
that's one of the biggest challenges we see. All the work we used to work with, the last thing the rural community that's underserved is pile on for that. That's a huge challenge. And so I think,
Especially now with the economy the way it is, and we can't get full staff of anybody in any of our businesses. Everything's a struggle, and to take on a new loan is, and the percentages of loans right now is just ridiculous. So,
Corny.
My name's Richard Adami. I'm at 20 years in the Army. I retired. I know all about leadership and having answers to your own questions, you know, knowing what the answer is, not just the gloom and doom. We can't do it because of this. We can't do it because of that. It costs too much money. We don't have the right transportation. All that stuff is probably true, but I wanted to hear some positive stuff. And my question is, because we're all tribes, and tribes used natural medicines, just like she said, we move from place to place not to overuse what was there. You mentioned COVID. I know that through my own use of plants and just being on the internet, that this plant called mullein is good for respiratory. You can use it as a tea. You can use it as a, one of those steam, you know. Everyone has those things for kids, and to help them breathe. Right. My question is, why can't we, as the tribes, we've got elders in our communities that know about these plants, these certain plants. They grow certain times of the year. They grow in this portion of the state and not that portion of the state, whatever. If we're going to be sharing things, we can share that kind of thing too. Can't we have something like that? If you have to put some sort of disclaimer on there and say, we're not, because you're the health profession and you have to say whatever it is. I don't want to hear the gloom and doom part. We can't do it because of this. Why can't we do it because we're native and that's what we used to do and that's what we need to do? And in my opinion, I mean, why can't we do that?
we can. We are.
I'm saying we share everything. Make a list of the stuff. Make a list of the stuff for, you know, everybody's using the internet now or their phones. Make a list of this certain website helps you with diabetes or with your blood sugar, or this one here helps you with breathing, or this one here helps you with your skin, or whatever plant we have. They grow all over the place.
Richard, I'll share. Oh, sorry. Keep going.
That's it. That's all I wanted to say.
Thank you for your service, too.
Yeah, thank you for your service, sir.
Yes, thank you. Thank you for that question. I love where you're going, and I'll say with that food as medicine pilot that the Iowa tribe is starting at the clinic, we actually have every intention. When we say food, we do also mean things like medicinal teas and herbs. We mean that. So whether or not the grant funds that we're receiving will allow for us to pay for those in our food as medicine prescriptions, we are going to be doing that. We have specifically created and preserved wild spaces for the foraging and for the wild plants. We have created codes to prevent over-harvesting. We have not been able to put into code if you have extra you need when you pick to give some to elders to share with the community, but that is actually a part of the agreement. So even though it's not a law, it's an agreement that if you get a permit to pick these plants, you are going to share with elders who are not able to pick them. And so what we want to do is actually use this pilot year to figure out how we can do it best, and share those lessons with other tribes, with other clinics. So if they want to do that, we can provide those things. The things we had to learn the hard way, we hope you guys don't have to learn the hard way by distributing those medicines through our pharmacy, by distributing those medicines through our food boxes, our commodity boxes. So I love that you share that. So the first year of this pilot is just for us to get the program launched and get a few lessons learned, but we do want to share. We want those.
If they ask, if they want it, yes.
If
Yes.
they want it, they.
You know who they are, right?
Oh yeah.
Yes.
So you can reach out to them.
I mean, before we had clinics, and before we had doctors, we had our own medicine, and a lot of our medicine worked. Why can't we use that?
Yeah. Right. Yeah.
Mm-hmm. And that's what we're going to get back to that. Our two nations are going to, right? As an, right. I mean, what works for some doesn't work for all.
People want to, prayer and, just your mental health. You're thinking, I'm doing this on my own instead of just popping another pill.
And I think today, even though we talked about those challenges, we also heard some great things that every clinic is doing, every tribal nation. But I do agree with you. We need to get to the point of continuing to share. And we've done this Kansas Tribal Health Summits every year. I think during COVID, we sort of stopped. And this was also a great forum for tribes to exchange that kind of information. But I think there has to be more discussion about how can we all collaborate and perhaps move forward with projects that involve all the 4 tribes. There's one more question back there, and I want to make sure that...
Arlene Wawasuk, Prairie Bend, Potawatomi. I was late getting here, I'm sorry, but I hear what Richard said about the plants, and it reminds me that most of that information has been taken away from us as Native Americans. We don't know how to raise our children because that was taken away from us. We abuse our children, and that was taken away. That was learned a long time ago when children were sent to these schools where they were abused, sexually abused, physically abused, emotionally abused. And that has carried through to our families to this day. And one of the problems that I see on our reservation, there's a lot of substance abuse. People just throw up their hands. Well, what are we going to do about it? I think tribes have the power to do something about it. Mm-hmm. It's in your hands, tribal leaders. Do something. Don't just wring your hands and say, what are we going to do? There's something can be done. Ask your community members. Take a boat or whatever. But there's just too much of it.
I assure you, ma'am, we are involved with that. And that is our number one concern. Us being simulated and not having our elders that pass down those traditions, it was a great loss. And we do suffer from that every day. And most drug addiction is self-medicating for the pain and the anguish that these people are dealing with every day. So I fully understand and I agree with you. Our old ways need to come back. And we need to find them.
Excuse me, I'd like to finish.
Okay.
One of the things I see that people can do nowadays is, what are your clinics doing to collaborate with everybody in your health service area? It's just not an isolated thing. Oh, we can't talk about so-and-so. It's these having problems. And, most of your health programs have people that can be helpful, mental health programs, behavioral health programs, Does the substance abuse programs refer those people to that can be healthy? I'm an old public health nurse, and one of the things I liked as a nurse was to be able to collaborate with other staff, other professionals, so that we can actually help families, help them to better health. You talk about diabetes. Most of our people, they don't know how to eat. You tell them, don't do this, that, and the other things, but they're going to do it anyway. I talked to an elder one time when I was working, and we talked about food amounts. And she said, well, what am I going to do when I go to Doan's and food is put in my dish? And how can I control that? And what I told her was, take a smaller dish. She laughed. No one thinks about simple things like that, and teaching our patients how to eat better. Plants are good, but eating is very important. How much we eat, what we eat. I see a lot of stuff here that diabetics shouldn't be eating. So that would be my question to you. What is your clinics doing to collaborate these programs so that the right hand knows what the left hand is doing? I think collaboration is very important in the healthcare system. Thank you.
I think we have, thank you so much. We're running out of time, so how about we have one person just address Arlene's question?
Okay, yeah, this is Jay from the Prairie Band Clinic. That's something we think about a lot, Arlene. Especially social services is not part of the health center, so how can we work with social services better? In fact, our home health aid program came out of that collaboration. We had some case coordination type meetings. We had some patients who had some severe needs, and it wasn't going to be one department or the other. It was going to be able to meet that need. It was a collaboration. So we started this monthly meeting where we can get together, and if we don't have certain patients to talk about, that's fine. We talk about programmatic issues, but it is a place where we can talk about those case issues that can come up, and so that's been exciting to see. And again, we all operate in a HIPAA environment with privacy, and so those meetings are quite controlled in terms of if it's not going to be programmatic and we're talking about a specific patient, we have to limit who's in the room and to those direct caregivers. But yeah, collaboration is important, and we need to get better at that, especially when we're not all health center and we have those different silos, as we used to call them at Veterans Affairs. I swore I'd never use that word again, but when we have those different silos, you've got to be able to reach across those departments and collaborate, and we're sure trying to do that.
All right, so this is the end of the panel. Thank you so much, Jay, Bridget, Misty, and Paul. You guys were amazing. Good job, Jay. And before you go, Nick wants to give you something.
Check. Yes, thank you, guys. And before we get started here, I just want to let you know what's going on. We're American Indians. We're a giving people. What I was told when I was growing up is our wealth is not always determined by how much we can get, how much we can accumulate. Our wealth is determined by how much we can give. You guys have a hard job. It's very tough, and you accepted it. You took it on. You came to, what did you say, Mayetta? And you said, first you said, what's a Mayetta? Yeah, that's kind of what we're dealing with in Oklahoma too, and I'm from Shawnee. I'm from a little town in Oklahoma called Shawnee. And we have 4 tribes whose their tribal jurisdictions go into Shawnee. It's the ASTs, Absentee Shawnees, the Citizen Potawatomis, the Kickapoos, and the Sac-and-Fox. And I've always grown up saying to my elders, thank you, elders, for speaking up, and thank you for being here. Richard, right? And I think Arlene. Yeah, thank you guys for being here. I hope my elders will show up at our functions there around Oklahoma. Coming to these things and speaking and getting out here in front of these people, it's hard. And then you're going to go back and you're going to work hard and nobody's going to see what you're doing. So we thank you. We appreciate what you're doing. It's a difficult task that you've taken on, and it's for the betterment of our people, because I grew up in Shawnee going to the tribal clinic there in town. It was rough. It was really rough. There was roaches in the corners, and you know, you were on that playground all day just waiting to be seen by the pediatrician, and maybe you got in, maybe you didn't. That slide was hot. You always burned your buns on that slide. It was rough, and it's way better now, and you're working hard to make that happen. You guys are going to keep doing that. We're all going to keep doing that. Everybody here in this room, we're going to keep doing that, make it a little bit better for each generation. So my two boys, Benny and Brandon, they're Kickapoo, Winnebago, Comanche, Navajo, all kinds of little mutts, basically. They're going to be able to have better services than I had. And so thank you guys for doing that. And Ponkawee, you got some gifts for them, right? You guys got some gifts? Olivia's going to give out the gifts. We've got for Jay, Prairie Band Potawatomi Health Director, right? Let's give him a big round of applause. Thank you. For Brigette, Sac and Fox Nation in Missouri and Kansas and Nebraska. Thank you so much. And Missty Slater, Chief of Staff, Iowa Tribe. Thank you so much. And Paul Austin, Director of Kickapoo Health Clinic. Let's give you guys a big round of applause and say thank you for your little gifts.